Well, good afternoon, everybody. It's a pleasure to be here. It's been a long time since I've spoken at a TOMA conference, and always enjoy being here, especially to present. But I always enjoy our lectures, and I hope this is an interesting topic for you. How many of you are interested in integrative medicine, functional medicine? Wow, that's great. How many of you actually use that in your practice? Some integrative techniques and okay. Good. My journey in integrative medicine started about 20 years, well, actually, let's see. It's been about 25 years ago. And like maybe many of you, I would see patients who would come in to the office and they would have things like chronic fatigue or fibromyalgia or migraine headaches or autoimmune conditions. And, you know, I could treat them and help them become at least partially symptom-free, but over time, it started to wear on me that I couldn't make my patients better. And so I started to just think about what else could there be? What other tools might be available? What am I missing, you know, in all of this? And I was actually getting a little bit disillusioned because after practicing, at that point, I'd been practicing for 20 years, and, well, 17 years. And, you know, you watch these people who are teenagers and kids, and they grow up to be adults. And you've watched them. They've been your patients the whole time. And when they would have some of these chronic conditions, I would end up sending them to specialists. And so many times the specialist would come back, and I mean, the patient would come back from seeing the specialist, and they would tell me that the specialist told them that they were depressed for their fibromyalgia, their chronic fatigue, and that's what they thought was going on. And yes, they were depressed, but that wasn't causing their fibromyalgia and chronic fatigue. That was because of their chronic fatigue and their fibromyalgia. So I was talking to a friend of mine who happened to be in real estate, and it has nothing to do with medicine. And he said, Michael, you should look into this. My cousin, who's a family doc, went to a conference on the root causes of chronic disease. Sounds like it's right up your alley. You should go. And so I went, and it was the most expensive medical conference I had ever been to. There were no pharmaceutical sponsors at that conference, interestingly. But it was a group of very bright people presenting cases about things that, you know, I would never have imagined. And some of those things I'm going to talk to you about today. And hopefully you'll be able to take home a couple of messages that you'll be able to use for your patients. So, the goals of the presentation. Basically, I want to have you be able to understand the magnitude of the problem. I also, and toxicity, demonstrating the environmental toxins that they can cause disease, chronic disease, and then really to underscore the importance of detoxification in maintaining and restoring health. Genetic uniqueness is extremely important. We're not doomed by our genes. Epigenetics is really the key, the things that affect the genes more. That could be anything from diet, exercise, nutrients, stress, toxins. All of those things could play a role. Toxicity starts in the womb. So there are 7 categories of toxins that I think of when I think of chronic disease, and I go over these with my patients to let them know. These are the things that I really think ultimately cause all chronic disease. First is toxic metals. Metals are bioaccumulative. When you're exposed to them, your body tries to excrete them as fast as they can. But whatever it doesn't excrete, it stores. Bone, organ, muscle tissue, that's what builds up. Mercury is the 3rd most toxic element on the planet. First is plutonium, and then it's polonium. Mercury's 3rd. Coal-burning electric generating plants. spew out mercury. Mercury from the plants, the coal-burning plants in China, because of the way the stream rolls with the atmospheric changes, it deposits over here. I'd love to tell you that there are still pristine lakes around, maybe out west in Colorado or someplace. But when they look pristine, but when you test them, they all have mercury in them. Who remembers the triad of mercury toxicity? Any of you remember the triad of symptoms for mercury toxicity? Anybody? Red as a beet, dry as a bone, and mad as a hatter. It can make you flush, it can dry you up, and it can make you crazy. Hatters felted hats in London. They used mercury as part of that process. They were inhaling that dust all the time. They went crazy. So where do you think we might get mercury? I'm sorry? You guys got to have some ideas. Where do you think we might get mercury?
Big fish.
Big fish? Yeah, big fish. That's right. It gets bioconcentrated in big fish. Tuna is the worst. What's that? Dentistry. Do we have any dentists here by any chance? Okay. Yeah, dentistry, amalgam fillings. You know, I think the other place that a lot of people, and it's, you know, we're more recently ingesting a lot more of it, is sushi, is where a lot of people are getting it. I don't know if you knew Tony Robbins was mercury toxic from sushi. So metals, first category. Chemicals, that's our second category. Microbes, foods, electromagnetic fields, EMF. I'll just say briefly on that. You know, we're into 5G, of course. We're not going backwards. There has been, there are papers published about harmful effects of electromagnetic fields, whether that's cognitive dysfunction, numbness, you know, neuropathic kinds of symptoms. And there have been cases litigated for that, for damages. So we know they're toxic, but we can't see them. And it's hard to know if that's what's affecting someone. And the only way I know to really try to determine if that's an issue or not is to fast from electromagnetic fields. And you know what that means. No phone, no computer, no Wi-Fi. How easy is that to do? Not real easy, but it can be done. And even in a slower or lesser intense program, you could start by not sleeping with the cell phone next to the head of your bed. You could turn off the Bluetooth and the Wi-Fi on your phone, leave the cellular on if you need it. At least that'll reduce some radiation. You could turn off your router at night. You could not keep your cell phone on your person. You know, everybody, they put it here, 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 just about any place you could imagine. And that's not a good idea. So emotional issues is the sixth category. I'm sorry, I'm not hanging with my slides here. Let me go back. Okay. Emotional issues. If you were to ask me if stress could kill you, I'd say, yes, stress can kill you. It's interesting that chronic stress, with chronic stress, at the end, there's some NIH studies showing that some of your natural killer cells don't fight with the same intensity as compared to when you're not under chronic stress. We also know that all of your hormones are in a well-choreographed dance at all points in time. So if cortisol, stress hormones, are up, then your other hormones are compensating. Thyroid, sex hormones, they're all trying to keep things in balance. And so that stress can be extremely toxic. And I like this. If a flower doesn't bloom, you fix the soil, not the flower. Unfortunately, in medicine, so often, we're treating the flower. You know, Pasteur said the germ is nothing, the terrain is everything. He and Béchamp, I guess they kind of gotten into a question about that and whether that was actually so. Béchamp was the one to first say that. Pasteur came up with it later, and the germ is nothing, the terrain is everything. And it's reported that on his deathbed, Pasteur recanted and said, yes, that's right, the germ is nothing, the terrain is everything. I really believe that. Every disease, it's at a mitochondrial level. Where do these toxins hit you? That's where they hit you. If you can't produce energy, you can't do anything. It's critical. And these things that we're talking about affect that energy. Metals. So lead, mercury, cadmium, aluminum, arsenic. If you look down, lead, mercury, and cadmium are cardiovascular toxins. Lead, mercury, and aluminum are neurotoxins. Lead, mercury, and arsenic are carcinogens. What do we have epidemics of in our country? Heart disease and cancer. Metals amalgam fillings are 50% mercury by weight. You can see them shining in there. We already talked about fish being a source of mercury. Some of the other things. Do you remember mercurochrome? The little pink liquid your mom used to put on the cut? It's a great antibacterial activity. I mean, it's a great antibacterial. But it's mercury. Unfortunately, we also still use mercury as a preservative in some vaccines. The flu vaccine has thimerosal in it. Thimerosal is a mercury-containing preservative, and it's used as a preservative because it's antimicrobial. But not everybody detoxes the same way. In other words, our bodies have a way to get rid of toxins. We know that. We can clear toxins from the body automatically. That happens every day. You urinate, you defecate, you sweat. We get rid of toxins, but not everybody does it as efficiently as the next person does. And those people who have trouble detoxifying are the people that are going to really be sick. So a dentist friend of mine, I want you to watch this video and then I'll tell you what. This is a video.
This lighting allows us to see mercury vapor from a 25-year-old silver amalgam filling. This filling was rubbed with a pencil eraser for just a few seconds. It will continue to outgas for over an hour. This amount of mercury is 1,000 times higher than the EPA allows for the air we breathe. View our website at holisticdentistpgh.com to learn about the serious health risks of having mercury in your body.
Okay, so they used a mercury vapor lamp. They took a tooth with that amalgam, and then they rubbed it with a pencil eraser. And it off-gasses mercury vapor, which we breathe. So when that happens, we breathe it, we swallow it. And, they rubbed it with a pencil eraser that stimulated, you could see how it enhanced the mercury vapor coming off of the amalgam. What happens in your mouth? Heat, friction, and pressure all stimulate that. So we're taking in mercury, we don't even know we're taking it in. A dentist friend of mine, it really drove the point home when he said, there are two ways an amalgam filling can get out of my office legally. I said, how's that? He said, in a biohazard bag or in your mouth. Two ways that legally can be done. Now tell me something. Is it not time to say we need to be done with those? Now, probably most of you go see dentists now who might use composite or ceramic fillings. Amalgams are much less expensive in the short run. But I think the toxicity that comes from that is significant. If you have amalgam fillings and you're going to get them removed, it's very, very important that you see a biological dentist someone who is trained in taking extra precautions when it comes to removing those fillings. They have a certain way that they cut them out. They don't just drill into them. It's called cut and chunk. They take those pieces out. And they also take extra precautions for what you're breathing at that time and that you don't swallow some of that mercury. So it can be taken care of, but we all need to be mindful that we're exposed. So this is just an article that talks about mercury exposure in heart disease, and it's a nice reference where you can see just the different things. Mercury exposure, even at low levels, can cause cardiovascular disease. It can cause reproductive and developmental problems. It's a neurotoxin, it's a nephrotoxin, it's an immunotoxin, and it's carcinogenic. Let me show you this case. So, 52-year-old male, contractor, burly guy. He's always done hard work. But he's very successful as a contractor. He likes to get in and do a lot of the work himself. He came to see me with generalized inflammation, sleep disorder, arthritis, and sinusitis, and he told me that about 8 to 10 years previous, he had arthritis in his hands, and then it progressed to his neck, and then it was his back, and then it was just generalized inflammation. He saw his primary care doctor. He tested negative for autoimmune conditions. They ended up putting him on tramadol. He took 100 milligrams of tramadol and 2 Tylenol every day just because he couldn't get out of the pain. And he was still in pain, even though he was taking that. He mentioned to me he felt better when he was in Colorado or Lake Tahoe, where it was drier, and the altitude also made him void more. I think that's interesting now, that he was better, because he was voiding more. He was using his excretion mechanisms to get rid of some of that metal. He saw a rheumatologist, like I said, everything, the diagnosis finally ended up being fibromyalgia. And I asked him about his work. And let me just say, too, the only way we're going to find out what's going on with the patient is if we spend time with them. And I know that's a nemesis for every one of us, is just how do you get it all done? And many times what has to happen is you have to just do serial appointments. I mean, you got to pick up where you left off. You can't get it all in one visit. So anyway, talked to him. He used to remodel homes. Like I said, he loved to do a lot of work himself. He did a fair amount of welding. He was doing some welding in crawl spaces at one time too. I can't think of anything worse than that. He had a history of multiple tick bites. He denied having any root canals or amalgam fillings. Now, we talked about amalgams and why that would be an issue. Root canals, let me just say, one of the problems that can come as a result of a root canal is a chronic infection called a cavitation in the socket. And that can be an ongoing source of inflammation. So that's another thing to think about in your patients if you can't really find out any trigger. Some of them will have an elevated, highly sensitive C-reactive protein, but a lot of them won't from that. And if you're suspicious, if you send them to a dentist who can do a cone beam CT, then they can pick it up on that cone beam CT. And a lot of the biological dentists will have a cone beam. I'm not talking about a Panorex, a cone beam. They'll have a cone beam CT that can pick it up, and then that would be just have that in your mind, especially if they've had a root canal. Many people have had several. So this guy progressively worsened. He couldn't do anything without pain. He couldn't have any fun. He used to love to get out on the jet ski. He was a guy who liked to, get the chainsaw out and cut wood, and he couldn't do any of that. So I did some initial testing, and part of that was looking at a blood level of metals like arsenic and mercury and lead, and his mercury level came back elevated. So I thought, that's That's interesting. So then I did what's called a urine provocation test. Remember I said that metals are stored in the body, they're bioaccumulative. So my question was, is he accumulating a lot of metal, or is this blood mercury level that I'm seeing just a representative of something he was exposed to in the last week or two? So a urine provocation test involves giving chelating agents. We do it intravenously. We use calcium EDTA. I'll say that again. We use calcium EDTA, and usually I'll use 900 milligrams of calcium EDTA, and we use something called DMPS. So it's a chelator that chelates mercury much better. So we infuse that into him, and what we do is we have the patient bring in a first morning urine when they come into the office for the test, and then we sit them in the chair and chelate them, and then anytime after we've started the chelator, we have them start collecting another urine specimen, and we have them collect it. They're in the office for about 2 hours, and we send them home with a container to collect for 4 more hours. So it's a total of a 6-hour collection. We send both of those urines off so that we can test them for metals. And we like to compare, one to the other. So in his first one, he really had no significant amount of mercury in his first test. But in his, can you see that well? So I take that back. So in his first test, it's that one. So the line that goes all the way out is mercury. I don't know if you all can see that, but that's mercury. Just above that, just a little bit of elevation, you can see lead coming out. So we had done his initial, the first morning urine that he brought in, he didn't have any significant mercury. We chelated him, and this is what we saw coming out. So the reference range, it should be less than 0.8. His mercury level was 13 on that. And this is after we'd been chelating him for a while. So his mercury level has come down. You start to see lead coming up a little bit. Well, actually, lead's just is a little bit better. So the interesting thing about that was when he came into the office for that test, I walked into the IV room, and he had started the chelating, and I said, "Hey, how's it going?" He goes, "What are you doing to me?" I said, "What do you mean? What am I doing to you?" He goes, "What are you doing to me?" I'm thinking, what do you mean? He said, "I'm feeling better. I'm feeling better." He said, "I don't know what you're doing to me, but something is making me feel better." The test, the provocation test, is also a treatment. I mean, we are pulling metals out of the tissue. DMPS is excreted through the urine. You're excreting that out. So we kept chelating him, and his symptoms went completely away. This guy had been sick for years. He'd been on the tramadol, pain. Tough guy. I mean, he would bull his way. He wouldn't feel like doing something, but he would just do whatever he could. He came back to see me. He said, "Man, I'm on the jet ski. I'm bouncing up and down. I could get my chainsaw going." He said, "That used to light me up, but now I feel better." So that was an eye-opening case. Then I have another case. So this one is a 48-year-old male. So in May of 2011 is when he saw me, and he had been having heart problems since 1998. So he had these 2 large amalgam fillings that were replaced in early 97. And soon after he had those amalgam fillings replaced, he started to have daily flu-like symptoms. Would never go away, every day, same thing, flu-like symptoms, aches. He developed aches in his sinuses, he developed aches in his ears, his throat, his neck. Had some numbness around his face occasionally also. And when I saw him, you know, he was giving me this history, and he had mentioned too that, you know, over a couple of months after having that process, that amalgam extraction, he started having some palpitations. He would get short of breath, lightheaded, and in May of 2000, he had another episode of lightheadedness that was much more significant. EMS was contacted. They found that he was in VTAC. He had an echo, a cath, both were normal. EP study showed that his heart was in and out of VTAC much more frequently. I mean, it shouldn't be in VTAC at all, but more frequently than you would see for a person who has an intermittent problem. So they placed an ICD. He did well for about a year, and in May of 2001, his symptoms came back. His defibrillator went off 19 times in the course of 2 hours. I can't fathom that. They found that his potassium was low at that time, so we replaced the potassium, and then he was started on some metoprolol and just continued doses of potassium. So he starts researching, and he finds a biological dentist. And this is before I saw him. And so the biological dentist, 2008, had his amalgams removed. She did a nice job, was very careful. And it was the first time since 1997 that his flu-like aches were gone. But the arrhythmias persisted. So this will give you a better example, what I was telling you on the provocation test. So this one is the first morning urine. Again, that's the one he brings in before we gave him the chelator. And we're trying to see, has he had some recent exposure to metals? And it doesn't look like it. Everything looks really good. Then we chelated him. Look at that number. Off the chart. It's out here somewhere. The reference is 0.8. He's 23. He's over there. So he's got that aluminum, little up to the a little elevation, but not bad. So we ended up chelating him. Spent I've been seeing him probably for I guess it's been about 10 years. And in that period of time, he has had to have an ablation. When he had his first ablation, he had his second ablation, he was still having symptoms. I was hesitant to chelate him because metals shift compartments when you chelate, sort of like stirring up the dust. You haven't swept the garage in 6 months, that's kind of like what it's like. And I didn't know if it might make him worse or not. So he kept saying to me, he keeps saying, would you just chelate me? Would you chelate me? Would you do that? So I finally told him, I said, look, you got to talk to your cardiologist and ask him if I can chelate you or not. And so he did talk to his cardiologist, and I think he hounded his cardiologist into saying yes, but he told me that we could chelate him as long as we made sure his potassium was okay. So we chelated him, and his arrhythmias start to get better. And he still has his defibrillator, but it almost never goes off. I mean, this guy couldn't go, he'd go to a ball game, he'd get shocked. He couldn't, family event, he couldn't really function very well. I admire him because he didn't stop going places, but it was difficult. So anyway, at this point in time, much better. And we continue to chelate him gently, and hopefully we'll have it where he goes, for a year or more without being shocked. His first year, well, actually, he has made that year. Hopefully we'll go a couple of years before he, and hopefully won't even have any after that. So second category of toxins, chemicals. The EPA estimates in 1994 alone, there were over 200 million pounds of toxic chemicals released into the environment. Per and polyfluoroalkyl substances, PFASs, may be responsible for hypertension in middle-aged women. That's something a little bit newer that's been looked at. They're called forever chemicals because they don't degrade. They don't break down in the environment. Look what they're used in. Teflon, Scotchgard, Gore-Tex, Stainmaster, all of those things. How many times do we cook something, or, you know, how do we put anything, do we ever put on a raincoat or something where, you know, it's water resistant? All of those things are treated. That's what these chemicals are. So I'll go into a little more detail about how this affects you in a minute, but I want to tell this one case study. There was Thomas Latimer, was a 31-year-old petrochemical engineer in Dallas in 1985. He went out one day, mowed his lawn, picked up brush, and about an hour later he gets dizzy, nauseated, experienced chest tightness, pounding headache, and ultimately has seizures. So his symptoms, they looked, and his symptoms were consistent with organophosphate poisoning. And he had had his lawn treated with diazinon, an insecticide, the day prior to getting out there and mowing his lawn. So he was treated, as I said, and he was okay for a little while, but then just continued to deteriorate with neurological issues. And they were trying to say, why on earth is he still having that problem? Because it shouldn't have been that huge an exposure for him to have all of these symptoms. And his symptoms continued on for 6 years. And then, with a little more history, they learned that he had, at the time that he was cutting his lawn, before he got sick, he was taking cimetidine for GERD. So he's taking cimetidine for GERD, that interferes with the P450 system. This guy couldn't detox from those exposures. And that's why his symptoms were lingering for such a long time. So he ended up being debilitated, unfortunately, long term. But I think it's important for us to realize, too, what things we're taking in and how they might affect us otherwise. Especially, I hope what you're going to walk away from with this is trying to clear out as many chemical exposures as you can. So look at this. Let me see if that's... Okay, so there are approximately 100,000 registered chemicals in the world that have hormonal effects. So this is something that's a big, big deal. Xeno means foreign. Xenoestrogens are foreign estrogens. Xenoestrogens have been in existence since 1991. They're said to be weak, but xenoestrogens have 100 to 1,000 times greater concentration in the human body than human hormones do, and they persist in fat for decades. So even though maybe they're weaker, the effects of them linger much longer. So a researcher, a wildlife resource researcher, decided he was going to do this little experiment. And they injected chicken eggs with DDT and DDE. DDE is a breakdown product of DDT. And they found feminization of the male's reproductive tracts. They also found typical female cells in the testicles. And in the cases of higher doses that were injected, they found an oviduct, the egg-laying canal, normally found only in females. And the other interesting thing, despite the internal findings, the chick looked completely normal. Xenoestrogens are a huge problem. And I'll go over that, some details on that in just a minute. But this Dartmouth study showed that plastic wrap heated in a microwave oven with olive oil had 500,000 times the minimum amount of xenoestrogens needed to stimulate breast cancer cells to grow in the test tube. Anybody ever done that before? Nobody? You got to be kidding. I'm the only one? I mean, quit using that stuff. Detergents, canned foods, commercially raised meats, because they're injected, typically, you know, the way you get a cow nice and fat, you put them in a confined space, you feed them corn, GMO corn, and then you put an estrogen plug in their ear. They gain weight. If I would recommend this website, I think this is a really good website, is ewg.org, and it's got some really good resources. You can find out, you can enter the names of certain chemicals or even household products, and they'll give it a rating as to how toxic it is or not. Watch your makeup, ladies. There's lead in lipstick and other kinds of cosmetics. It's very surprising when you look at that. And so there's a part on that website that's called Skin Deep. So environmentalworkinggroup.org, Skin Deep, you can get into that part, and it's really helpful for determining what you should be putting on yourself. So when you think of toxic chemicals, what comes to your mind? What do you guys think is the most, what's the toxic thing that you have in your house that you think? Say again? SLS? Sodium lauryl sulfate's on that list. The most common thing, though, that I see that people will say that's toxic is Roundup. And I'm just telling you, it's not worth the pretty driveway. I have 9 children, and some of their friends, their families will use Roundup, and they'll spray, Roundup to clean up the driveway and the fence row and that sort of thing. And one of the friends whose family uses Roundup like that, asked one of my kids, "Well, what does your dad use?" And they told him, "He has 9 children." I got weed killers all over, and every weekend in the yard, that's where we are. They are. So it's not worth it. Roundup is a carcinogen. It's a hormonal disruptor. You can look online and you can find natural weed killer, a recipe for it. You can find that. Does it work as well as Roundup? No. Does it work? Yes. It does. It's slower, but it works. And just look it up, recipe for natural weed killer, you can find it there. What diseases come from chemicals? Diabetes, hypertension, cancer, neuropathy, sexual dysfunction, infertility, PCOS, obesity. And I just wonder, where's that coming from? It's an uphill battle to admit to yourself that you feel like your gender is not what it should be. But I wonder if some of those same things are happening chemically in people who have that problem. It's obviously something that will change somebody's life forever. So we'll talk about remedies in just a minute. How much time do I have, by the way? Has anybody got I have 20 minutes? Okay. So next category of toxins, microbes. Bacterial, viral, mold. Now, on the bacterial side, I think of Borrelia, Babesia, Bartonella, Ehrlichia, and Anaplasma. I think of tick-borne diseases. And I'll tell you, that's so contentious. You see there, I said the controversy in Tennessee. How many of you have diagnosed someone with Lyme disease? You? Okay. I'll bet you every person in here has a patient who has Lyme disease or a tick-borne disease. Testing is not as sensitive as it should be. And do we have any infectious disease people here? Andrew was here. Every infectious disease doctor that I've ever met is extremely bright. Every one of them that I've ever met. They blow me away. Somehow, the dogma has been transferred down that Lyme disease does not exist in the state of Tennessee. Now, I've had multiple patients come to me who've been to the chief of infectious disease or someone in the department of it, the chief and other people in the Department of Infectious Disease at arguably the most prestigious institution in this state, and they go there with their symptoms, and they say, these are all my symptoms, here's what happened, and I don't, did you remember a tick bite? No, I don't remember a tick bite. Have you traveled outside of the state of Tennessee? No. Then it's not Lyme disease. That's what they're told. It's not Lyme disease. Now, and the statement again is Lyme disease does not exist in the state of Tennessee. There is no human being that could make an absolute statement like that. You have to claim to know the knowledge, to have the knowledge of every tick in the state of Tennessee, because ticks are here. You have to claim to know the status of every one of them that's here to be able to say that Lyme disease does not exist in the state of Tennessee. And beyond that, we see it. Veterinarians are diagnosing it. Ticks get on movable animals that travel across the border. We can't even keep illegal aliens out. You talking about ticks? Birds carry them too and drop them off in different places. So all that to say is we need more sensitive testing. I use specialty lab testing to look for this. And Borrelia, I don't know how much, typically these kinds of things, really the history is so critical. That's really where you're going to find out how to come to the diagnosis. How many of you see fibromyalgia chronic fatigue patients? Only a couple. Wow. The rest of you anesthesiologists or no chronic fatigue? No chronic fatigue, fibromyalgia? Okay. How many of you love to see chronic fatigue fibromyalgia patients? I used to hate to see chronic fatigue fibromyalgia patients. But I don't hate to see them anymore. Because 9 times out of 10, I can help them. And if we can identify the root cause, that's it. It's the solution. The symptoms go away. Don't treat the flower. Treat the soil. We got to do things to make ourselves more or less vulnerable to toxicity. Our immune systems need to be stronger. Our diets play a tremendous role. We eat way too much sugar. You want something that'll shut down your immune system, especially your natural killer cells? Have some sugar. 2 pieces of whole wheat bread, it's like 2 tablespoons of sugar. That's what happens in your body. And it'll shut down your immune system. We got to be better about it. We need to bring that example to our patients. One of the things that I think is, 2 things that I say would be very helpful, I believe, in the diagnosis of borreliosis is there are 2 markers. One's called a CD57, the other one's a C4a. CD57, it's a CD8, CD57 natural killer cell, LabCorp, Quest, they both do it. It typically tends to be low in people who have Lyme disease. The C4a, it's a complement protein made by the liver, complement activation, it's part of your immune cascade. It tends to be high in people who have Lyme disease. Now, is that diagnostic? No, but I'm looking for clues. What's causing this person's fibromyalgia? Why do they hurt all over? Why do they have this rheumatoid arthritis? So we look at these markers, and then of course we have to end up somehow looking at a test for the actual organisms. And I don't think I can say the name of labs up here, but if you have a question about it, I can tell you afterward, outside or something, what labs I use for detecting that. And the clinical history, again, it's your biggest key. Also under the microbial category of toxicity, chronic fatigue. I don't know how many of you do you check Epstein-Barr virus titers with chronic fatigue patients? Good. Do you check the early antigen IgG antibody with that? So if you just order the routine IgM, IgG, you're going to see whether you have an acute case or a history of a case of mono. But if you order the early antigen IgG antibody along with it, you will see oftentimes IgM is negative. The IgG, the other IgG is positive, and the early antigen antibody is positive. If that early antigen antibody is positive, that tells you it's reactivated. Reactivation of viruses is not anything new. You know, that's what shingles is. By the way, does anybody else feel this way? When I was a resident, when I was a resident, I can remember shingles occurring in people who were like 70 years old or on steroids or chemotherapy. What do you think's happened? I mean, surely, anybody else seeing shingles in 20-year-olds and teens? What do you think's happened? It's our immune system. It's these 7 categories of toxins: metals, chemicals, microbes. It's these things that are knocking our immune systems back. Pandas, anybody familiar with pandas at all as it relates to strep? Pediatric autoimmune neuropsychiatric disorders associated with strep. A lot of kids deal with this. We see a lot of quirky kids, maybe, got a tic, a tremor, something going on with them, ADD, ADHD. Most commonly, what we see is anxiety, OCD. That's the most common symptom complex that I see. And it's like this child is normal, and then all of a sudden, they're obsessing. They can't stop. I've even seen, interestingly, bladder tics. Now, that gets rough when you're trying to spend the night at, a friend's house. A bladder tic, a tic's an involuntary move. You can't just shut that down. So they have a difficult time. But typically what I'll look for, the tests, it's a clinical diagnosis. You can read the studies on it. It's a clinical diagnosis. That's it. But there are things that can lead you to that also. One is an ASO titer, and one is an anti-strep DNase B titer. So the anti-strep DNase B titer is an autoimmune marker. The ASO is obviously just a marker for infection. But if I see an ASO, an anti-DNase B, and I get that history that everything was going well, and then all of a sudden they don't want to go to school. Or, they're having they're developing these tics. They're making up little noises. They try to suppress them. These kids are worn out at the end of the day because they've been trying to suppress their tics all day at school. But there's also something called PANS. So there's PANDAS, which is strep-induced autoimmune neuropsychiatric symptoms. And then there's PANS, which is a little different, pediatric acute onset neuropsychiatric symptoms, is basically PANDAS caused by another organism. And our old friend Borrelia is often in that mix. So, microbes, mold. Anybody ever have a patient with mold toxicity? Okay. This is a case of an 8-year-old female. She was diagnosed with seizure disorder. She came in with both parents for evaluation, and she was developing normally. Met all her milestones. She was early, multiple words at age 1, sentences at age 2, was doing really well until around age 3 or 4, when her Sunday school teacher told mom that the patient did not know her colors. So she also seemed to have problems grasping new concepts, and mom thought it was just a learning style. She didn't think much of it. But in mid-second grade, mom noticed that the patient couldn't remember things that she was taught the day before. And then one day at age 7, the patient was lying down watching a cartoon, TV, and she has a grand mal seizure. She goes to the ER, exam's normal. She gets referred to neurology, sees the neurologist, MRI of the brain's normal, 24-hour EEG showed abnormalities about 40% of the time at night. They came up with the diagnosis of electrical status epilepticus during slow-wave sleep, but her seizures were only occurring about 40% of the time, and the diagnosis really technically can't be made unless it's happening less than 70% of the time. So neuro couldn't give her the diagnosis, but they started treating her with Depakote anyway. Mom did not want her to be taking anti-seizure medications. I mean, she didn't mind. It was okay because the patient had seizures that she could treat her, but she didn't want this to become a long-term problem for her. So then as we got into the history a little more, it seemed like the seizures primarily were happening either while in church or just after being in church. I suggested it was probably conviction, but actually what was happening, her dad he was one of the pastors at the church. And they were thinking, this is a spiritual attack. This is something that's, this doesn't make sense. I mean, I can't be a pastor and my daughter not come to church. This isn't right. So I did a test called an HLA-DRB-DQ test, which is a genetic test that tells you a little bit about celiac predisposition, but it also tells there's a website for an HLA calculator. And if you do the HLA-DRB-DQ test, and I'm sorry I don't have a copy to show you what it looks like just an old-time computer printout of symbols and numbers and things, but you can find out whether somebody has a more difficult time detoxifying from neurotoxins like mold toxins or toxins from Borrelia by looking at their HLA status. Some people, no problem. Other people, when you plug your data into that HLA calculator, it'll say mold susceptible or multi-susceptible. And so those people who are mold susceptible or multi-susceptible don't clear those toxins as well as the next person. So Dad was really having a hard time with this because he said, I'm fine. And most of the other kids are fine. So I don't know what's going on with her, but it was almost like he was blaming her, but he was so conflicted because of the fact that he's a pastor at the church and he's on the staff. This was very difficult for him. So we ended up doing a mycotoxin panel and also a C4A. Now remember that C4A, I said it can be elevated with Borrelia and mold. Again, it's not diagnostic, and other things can cause those changes, but it's one of the things we look for. And then we did this mycotoxins test. So on this mycotoxin test, all it's telling us, different types of molds, you see different types of molds produce different types of toxins. Aspergillus there can produce something called aflatoxin A, and it can produce other toxins as well. Then you look at another toxin, another type of mold over there, that's penicillium. And you can see down here mycophenolic acid is really high. This one's, ochratoxin A is off the chart over there. So interesting thing about mold, it's difficult to find. You'd think that, it would have to be some place where you see green up and down the walls or, lots of water stains on the ceiling tiles or something, and it's not always like that. You're lucky to be able to pick that up if somebody can see it. It can be behind the drywall. And people come in and to do air sampling, and I've seen multiple tests. 7 different companies come in and test, and they say it's nothing worse than outdoors right here. This is fine. So it can be difficult to convince people that, hey, this could be a problem. So with mold, what do you do about it? First thing you have to do is you have to get rid of exposure. She could not go to church. I said, she cannot go to church. That went over real big, too. She cannot be there. Mom also started to have some symptoms. Hers were milder, but she started to have some symptoms as well. So again, it was very stressful in the family. We started them on some toxin binders. She got better. She was having occasional seizures. The interval between seizures was lengthening. I can tell you that today she is off of any medication. She does not have any seizures. Her mycotoxin levels are low. They've moved. They changed churches. They had to go to a different building because they had the church tested. They couldn't find any problem with it. And so what you use with these biotoxin illnesses are toxin binders. One really good one is cholestyramine. Cholestyramine can work really well. The big problem with cholestyramine, as most people probably know, is the GI side effects. But you can start it with even low doses, and usually maybe start with, if you're using the powder, a quarter teaspoon or something, work your way up, you can get there. Another one that's really good, this is in the supplement category, it's modified citrus pectin. Modified citrus pectin is really, you look into modified citrus pectin, it's pretty interesting, very helpful, actually helps to pull some metals, but really good as a toxin binder and well tolerated. All right, let's talk about food. Oh, wait a minute. Oh, I left you guys out. I'm so sorry. Somebody tell me if my slides don't change. So foods. What foods do you think would be the most toxic? Bologna? Why would you say that? That high quality cut. What's that? Nightshades?
No, nitrates.
Oh, nitrates. Okay. Okay. Nitrates in foods. Anything else? What do you think what food triggers the most reactions that you know of? What do you think? Peanuts. Peanuts are high. Yes. Guess what's, not only are just the peanut and the peanut oil is pro-inflammatory, but the fact that peanuts also, things get sprayed is another big issue there. And other foods. Oh, thank you. Who said gluten? Yes. You know what's interesting with gluten, I've had patients who come in and they don't have celiac disease, but they're gluten sensitive. They have the GI symptoms that go along with it. I've had them come in. There was one couple that came in and they were going for their anniversary. They were going to Italy. She has celiac disease. Celiac. And I said, talk about, stepping up to the line, seeing if you can keep from falling over. I said, I can't recommend that you eat the wheat products. She said, I understand. So they went to Italy. First day. They sit down at a little cafe. They eat. No symptoms. They have, again, pasta. No symptoms. They eat the bread. No symptoms. I hear the same thing from people who go to Mexico, and particularly Mexican beer. Mexican beer, different kind of gluten. It's not all the same. Not all the same. So gluten can be a big problem because we know it can induce autoimmune disease. Where am I? 2 minutes, 3 minutes? Oh, I'm sorry. So it can induce autoimmune diseases. But let me talk about milk for just a second. How many of you have trouble digesting milk? Dairy? Oh, the rest of you can tolerate okay. All right. Your family might disagree. I don't know. But casein comes in two forms, A1 and A2. A1 is the most common type of casein, so that's available on the market. And the reason for that is Holstein cows make A1 casein, and they produce more milk than other types of milk cows. So they use Holsteins. Most milk is A1 milk. Jersey cows and Guernsey cows produce A2 casein, and it's much better tolerated. I know you can find it at Publix. I don't know about other places, but your local farmer, if you happen to get some milk, would know. And that's one thing for a common digestive issue and allergy issue. I see skin problems, not just digestive problems, can be a problem. Okay, now, treatment. How many of you think the outcome of your treatment plan has something to do with the level of confidence the patient has in you? How many? A few of you. Not even half, maybe. Okay? Has a lot to do with it. It has a lot. NIH, down at the bottom, you see this from a clinical perspective. Patients reported more beneficial health behaviors, less symptoms, higher quality of life when they had higher trust in their healthcare professional. How many of you touch your patient every time you see them? Every time. Good. Proud of you, man. I don't know if you hear it, but I hear it. I send the patient to the specialist. He go to the cardiologist. The cardiologist thumbs through the chart. And I said, well, what'd they say about how your heart sounded? Never listened to my heart. I don't care if you have the echocardiogram, the EKG, the stress test, the cath. It doesn't matter. You're a doctor. Touch your patient. Does anybody believe in energy medicine? Do you believe that we're energetic beings? For crying out loud. Yes. And we can all feel it at different times. You know, people can drain you or they can boost you up. Hang around with the boosters. But it's important to touch your patient. Not only that, it's not just because of that. You know how many times I've picked up a Bernui that I didn't hear before? I missed it before, but I hear it now. Or a murmur. They never told me I had a murmur. Well, I mean, I hear it. I think it sounds benign to me. I don't think we really need to do much, you know, here. But those things make a difference. There's healing in your touch. Thyroid nodules, thyroid enlargement. Get good with that palpation. Foods. Oh, gosh. Okay, I'll make this quick. 55-year-old lady came to my office. She was running 3 companies in Nashville, very bright, executive type, developed chronic fatigue and abdominal pain. Labs and imaging were normal. She was so tired she just couldn't work anymore. She was single. She had no children. She ends up losing her job. She's living with friends. One friend over here, for so many weeks, one friend over here for so many. She was like a street person, this really bright lady. So she had some abdominal pain still, so I referred her for colonoscopy. Everything was perfect on the colonoscopy. And then she comes back in to see me, and she said, I want more of those meds. I said, what meds? I'm thinking she's in for sedatives now, this is not good. No, not those. The ones that you take beforehand. I said, nobody asks for those meds. So she said, but I'm better. My fatigue is gone. I haven't felt this well in years. And then it dawned on me. It wasn't the prep. She fasted. She didn't put anything in to antagonize her GI tract. She was better. I already talked to you about emotional categories. Stress, can it kill you? Probably the most hidden toxin that is the most potent that I see is a lack of forgiveness. And I'll tell you, this is just the way my practice works. I spend 2 hours with a new patient. And we go through everything, their upbringing. I start with, were you a C-section or vaginal delivery? And we work our way up. And I tell you what, man, my heart is heavy so many times I come out of that consultation room because I cannot believe what some people have to bear. But the ones who do well are the ones who will say, it's not okay what happened. It wasn't okay. It's not okay now. It won't be okay in the future, but I'm going to release you from the debt. You can't pay me. But I'm just going to let it go. And I would encourage you, we all have those times. We've all had those people. Every day, write it off. So I hope you have come away with a couple of things that you can use. There's hope. Even for cancer, there's hope. The body has a tremendous capacity to heal, you know that. It's a mitochondrial disease, cancer. When you start getting these toxins out of the diet, out of your environment, and I'll tell you the diet that I believe works best, although it's not, we're not all genetically the same, of course, but the ketogenic diet is extremely helpful. When you drop sugar, sugar feeds cancer, you know that. It cannot burn fat for fuel, but you can. So if we get the sugar down, burn the fats for fuel, then we can start starving cancer that way. And then if you add intermittent fasting, it's a game changer. How many of you intermittent fast? Anybody? Okay. So, you could do longer fasts, but intermittent fasting, you eat within that 8-hour window, autophagy kicks in while you're fasting. So it's like disk cleanup on your computer. Immune system gets activated, you take out all this garbage cells, and you have a chance to be better. Thank you for your attention. It's a pleasure being here.